Chiari is one of those things where if you look it up on the internet, you're gonna be terrified. There's a lot of confusing information there. What I can say is I am confident in what Bobby Jones, Chiari Syringomyelia Foundation puts up. It's vetted by professionals. So that is a trusted source for online information. So throw that out there as a plug. I do not work for Bobby Jones. I am not compensated by Bobby Jones. I am on their board, their scientific board. So again, I'm Brendan Rocque. I'm a pediatric neurosurgeon here at Children's of Alabama. So let's talk about Chiari. And I have a bunch of slides here, and some of them are like intended for a medical audience, so we'll try to muddle through them. Some of them are more for a lay audience, but we can just chat as we go, okay? So let's start from the beginning. What is Chiari? So that's a weird name. Why do we call it that? Well, it's because of this dude. His name is Hans Chiari, and he described the Chiari malformations. He described 4 of them, and the rest of them are not important for this talk. Chiari I is all we're going to talk about. The others are totally unrelated. They just happen to be described by the same dude and involve the same part of the body. So you say, well, what about a Chiari II? Do I have that? You do not. That is a totally different thing, and we're not talking about that today. So Chiari I. So what is Chiari I? If you guys have been to my clinic, some of you have, you've heard this talk. So at the bottom of your skull, you have a large opening, a big hole. It's called the foramen magnum. That's Latin for big hole. Right? It's about yay big. It is where the spinal cord comes out. Right? Spinal cord, as you know, is the connection between, I don't know why that's doing that. All right. Well, I'm using the cable that they provided. Maybe I'll switch to my cable and see if it works better. Hold on a second here.
When he fixes that, Anastasia here is our head of research for children. She's wonderful and amazing. And Morgan here is our newest, so 6 months ago, NP for pediatric neurosurgery.
All right. So we were talking about the big hole. At the base of the skull, a large opening, it's called the foramen magnum. The spinal cord comes out of that opening. Spinal cord is the connection between your brain and the rest of your body. So the opening is about yay big. The spinal cord is about the size of a thumb. So there's plenty of space. And around the spinal cord is spinal fluid. It swishes in and out of your skull every time your heart beats. That's the normal situation, right? So what is Chiari? So Chiari is when the back part of the brain, the cerebellum, kind of hangs down into that hole. What we're looking at here on this MRI scan and on this drawing, so it's like we took a slice right down the center, and we're looking at it from the side. So the front is over here, the back is over here. This is the cerebellum. This is the opening right here. So from there, that's the back of the opening. There, the front of the opening. You can see that line that we draw on the MRI scan. That shows where the edges of the foramen magnum are. And Chiari I is when the back part of the brain hangs down into that opening. So it's kind of like a plug. It takes up some of that space that's normally filled with spinal fluid. So how do we know what is a Chiari and what is not? So you get to our clinic when you meet this magic number of 5 millimeters, right? We measure how far down your cerebellum goes. Does it go 5 millimeters outside of the foramen magnum? If so, the radiologists call it a Chiari. But there's nothing magic about 5 millimeters. It's a number that actually comes from one paper published in 1985 that had 20 patients in it. So this is an absurd thing that we use this 5 millimeters as this magic number, but everybody uses it. So if you get an MRI scan and you have tonsil position, tonsils are the part of the cerebellum that hangs down, right? If your cerebellum, your tonsils are 5 millimeters outside the foramen magnum, you are going to have the label Chiari applied, and you're going to be sent to see somebody like me. And so that's, turns out, a lot of people. So there's a couple of studies. The best ones are from the Netherlands and from Michigan. They did screening MRIs on like 2,000 people, just totally asymptomatic, just on the streets. You know, volunteers came in, got an MRI scan. And Chiari is present in about 1% of adults and 3 or 4% of children. So Chiari, let me be clear. That 5 millimeter tonsil position, right? If we use that as the cutoff, it's 1 to 3% of the population. So that's a lot of people, right? That doesn't sound like a lot of people, but that's a lot of people. But just like anything else that you measure, have you guys ever seen this is called a normal distribution, right? So if you take a measurement of something, there's going to be a lot of people who are in the center of of the range of measurements, and there's going to be people that are outliers on one end or the other. All right, this is a graph of where I think this was about 2,400 people where their tonsils were, and most of them are right at the level of the foramen magnum. And then you've got a bunch of people whose cerebellum is up inside the box, right, which we think of as normal. But we also have a bunch of people who have a little tail, where there's plenty of people that have cerebellum outside of the foramen magnum, 2, 4, 6, 8, whatever millimeters outside, right? So this is actually pretty common. It's a normal distribution. I'll give you another example of a normal distribution, right? This is self-reported height by American men. And you can see it's a nice, perfect bell curve, except for all the people who lie and say they're 6 feet tall. So average is like 5'9", 5'10", right? And then a bunch of people, so that extra bump over there is the people who are not 6 feet but say that they are, right? The MRI doesn't lie about your tonsil size though, so this is real here. All right. So these are some actual pictures, people with Chiari. You can see there's a lot of variation of how far down the cerebellum goes. Everything's different shapes and sizes. So if we can't make a distinction or a decision about is this an important thing for you based on the pictures, well, what can we do? And that's the real question that we have to struggle with, right? Who's going to benefit from Chiari surgery? I don't have a lot of slides about what the surgery is in this talk, but I'll tell you, just briefly. That's kind of beyond the main scope. Basically, Chiari surgery is about making the opening larger. Right? So we move the skin and muscle out of the way. We take a little window, about 2.5 centimeters worth of bone, off the back of the skull. We remove the back part of the first cervical vertebra, so that's taking the bone off. That makes more space, and then we may or may not open the dura, that's the covering of the brain and the spinal cord, and sew in a little patch to make that bigger as well. Right? So that's the surgery. It's a pretty simple, pretty straightforward surgery, but of course every surgery comes with risk, and if the surgery is not going to help you, then we don't want to put you through it. Right? So this is the major question that we have to answer in our field, in Chiari, is who's going to benefit from Chiari surgery? Now, what is the most common reason that people end up getting an MRI scan? It's headaches, right? We know that 3% of children have Chiari, 40% of children have some type of headache that they struggle with at least some time in their life. What we do not know is how many people fall in that overlap there with headache and Chiari, and most importantly, we have some ideas about what type of headaches are going to respond or are caused by Chiari and therefore are going to respond to the surgery. And we'll get into that in some detail here. Now, we're having this talk in Birmingham, Alabama, and I'm the one giving the talk, and so I have to give you the disclosures that I was trained by these two dudes, right? So this is Benny Iskandar. He practices at the University of Wisconsin. He's been there since 1997. This guy over here is Jerry Oakes. He practiced here, he's been there since 1993. He retired in 2017. I was a resident with Iskandar in Wisconsin. I was then a fellow here with Oakes in Birmingham. And I should also mention that Benny Iskandar did his fellowship with Oakes too, so it's all one philosophy towards Chiari. Right? And what I learned from these guys is the following, right? If you have headaches that are at the base of the skull, the top of the neck, they are worse when you cough or sneeze or strain, like to lift something hard, right? Laugh really hard, really exert yourself. They are sharp headaches. They're quick. They don't last super long. They get better kind of quickly, right? But they can be debilitating. That kind of headache is almost certainly going to get better with Chiari surgery, right? If you have syringomyelia, we haven't talked about that yet. So what is syringomyelia? Syringomyelia is a buildup of fluid in the spinal cord itself. You can see the arrows pointing to it. I can get my pointer out, but the arrows are already there. All right, so that long gray ribbon there is the spinal cord. Again, sliced right down the middle, looking at it on an MRI scan. It's not supposed to have fluid in the middle of it. That's what syringomyelia is. Sometimes we get people sent to us that have a really tiny, thin amount of fluid in the spinal cord. Now, it turns out that all of us have something called a central spinal canal. It's a super thin, fluid-filled canal in the middle of the spinal cord. Usually it's so small you can't even see it on an MRI scan. But just like everything else, right, some people have a bigger than average central spinal canal. It's like 2 or 3 millimeters. We can actually see it. So that will often get you a referral to the neurosurgeon as well, if somebody sees a little bit of fluid in your spinal cord. Little bit of fluid is not a big deal, right? That's a prominent central spinal canal. Some people have them, not a big deal. It's when the fluid is building up and blowing up the spinal cord again, like that long skinny balloon. That's a problem. Why is that a problem? Because eventually it can cause problems with the way the spinal cord functions, right? Spinal cord is the connection between your brain and the rest of your body. So if your spinal cord is not working properly, you start to lose function in the arms and legs. Often it starts in the hands. It can be like tingly hands, loss of dexterity. It can lead to problems with legs and walking, things like that, right? So we know that if you have a syrinx, or if you have life-dominating, debilitating posterior headaches that meet all those criteria, every neurosurgeon in the country is going to say, you are a good candidate for surgery, and we need to do an operation to decompress your Chiari. And the syrinx will almost certainly get smaller. It may not go away completely, but as long as it gets smaller, that's a good thing. And the headaches will almost certainly go away or be substantially improved, right? This is what is accepted. Everybody is on the same page when it comes to that. All other types of headaches in the Iskandar-Oakes world, not Chiari related, less likely to respond to surgery, and generally we would not offer an operation for those conditions. Okay. Now, I'm going to question that dogma in a few minutes, right? Is that really the way we should do things? This is Dr. Oakes' classic paper. It was published, what is it now, 15 years ago. His first 500 patients that he took care of with Chiari. We learned a lot about what the patients looked like, what symptoms they had before surgery. And you can see on there that there's not just headache and syrinx, right? There's other stuff on this list of symptoms that even Dr. Oakes operated on. Dr. Oakes' paper doesn't really tell us what happened to the patients after they had surgery, unfortunately. So we got to have something else. We got to have some studies to understand how people do after the surgery. And this guy gets some credit for that. This is David Frem. He used to be in charge at the University of Chicago. He died, unfortunately, a couple of years ago. He created this Chicago Chiari outcome score. And you don't need to worry about what it says, but this is a paper. There's about 150 patients where they did the Chicago Chiari outcome score. Focuses on, did you get better after surgery? And look at that. So many people got better, right? There are symptoms like dizziness, dysphagia means difficulty swallowing, tinnitus is ringing in the ears, syncope is passing out. Lots of people that had those symptoms got better after surgery. So that begs the question, are we missing some people who could get better with Chiari surgery because we're not offering them that operation because we're worried only about headache and syrinx? Keep that in mind as we go forward. If you've been to my clinic, I've talked to you about these things, right? You're a candidate for surgery if you have these terrible headaches, if you have Syringomyelia. And there's one other thing that is not on the Oakes list that's actually more recent than Dr. Oakes' practice. It's what we've discovered in the last 10 years or so, and that is sleep apnea. So it turns out, what is sleep apnea? Sleep apnea is pauses in your breathing while you're asleep. All right, so your brain is what tells you to breathe, and while you're awake, sitting here, you're breathing. And now that I'm talking about it, you're all thinking about it. But you realize that you can breathe both consciously, right, doing it the way you want to, and if you're not thinking about it, it happens automatically. While you are awake, you're obviously going to keep breathing, but sometimes if you have sleep apnea, while you're asleep, there are pauses in your breathing that can happen, right, because you're not thinking about breathing. That's abnormal. That's caused by compression of the brainstem, right, which could be a Chiari symptom. So is Chiari related to sleep apnea? And this is work that we did here at the University of Alabama, Birmingham at Children's. We said, okay, this actually looks like there may be something to this. So we started sending every patient that came through the clinic for a sleep study. Some of you have been to my clinic. I've probably referred you for a sleep study. I had to convince Dr. Roselle that this was a good idea. So you got a sleep study because of this too. And this is what we found, right? Almost 50% of people that came in with Chiari, regardless of what their symptoms were, had SDB, stands for sleep disordered breathing. That means some type of sleep apnea. There's a number of different types. We don't have to worry about the details. That's a lot. Lots of different types, right? Again, we don't need to worry about the details. But then this was not a study where people had to have sleep studies or et cetera, et cetera. But, so we have a much smaller number of people who had sleep studies both before and after surgery. But if they did, their sleep apnea got a lot better. All right, so based on that, we now say, okay, if you have sleep apnea, regardless of whether you have the headaches or the syrinx, you're a candidate for surgery, and I think that's probably the right thing to do. Okay, before we get to the questions that you guys want, that I want to talk about still, I want to answer these two additional questions. If you don't have terrible posterior headaches, we call them tussive headaches. Tussive means coughing, so they're worse when you cough, right? So you don't have tussive headaches, you don't have a syrinx, you don't have sleep apnea. Am I going to get worse? Right? This is an important question. And then we'll get to the other one, what about other symptoms? So how would we figure out if you're going to get worse? Well, what we need to have is a whole bunch of people who don't have those symptoms and they don't have surgery, and we follow them over a long period of time. And here I have to give Dr. Oakes credit, because this is what he did with all of his patients. If you came in to see him and you didn't think you needed surgery, he'd have you come back again in a year. Get another MRI scan, make sure everything's still good. If you still didn't think you needed surgery, you come back in 2 years. If you still no, 4 years. And all of us here, we live in Dr. Oakes' world, so we kind of practice the same way. So what that allowed us to do is put together a study of a whole bunch of people. Now let's just clip through this. So we ended up with 430 patients who had no classic reason for surgery, followed over 300 of them had at least a year of follow-up, over 100 had more than 5 years of follow-up. And what we found is that only 15 people, so about 3%, develops one of those symptoms that we think was classic Chiari over that time period. So that's a pretty good record. This is called a Kaplan-Meier curve. This is how we, when we're doing research, this is how we display something that has to happen over time. So it's more impressive if you've made it longer. Right? So this has time here and how many people needed to have surgery. And you can see that's 75%. So we're only looking at the very top here. Only about 7% over 10 years ever had to have something done. So what we learned from that is that if you don't have those classic symptoms, you're very unlikely to develop those classic symptoms over time. Right? Based on that, we've been a little bit more aggressive, a little bit less aggressive about getting follow-up MRI scans if you're not having any significant complaints. All right, so will I get worse? Probably not. But what about other symptoms, right? I'll tell a couple of stories. So this is a 11-year-old girl. She had headaches in one side of her head. They were associated with photophobia. It means she didn't like bright lights. When she's having a headache, bright lights are a problem. That's pretty classic for migraine headaches. Migraine headaches often run in families. Bright lights, loud noises make them worse. They come with sometimes other sensations like tingling or weakness. We don't think that they're Chiari related. What I tell you in clinic, as you probably heard me say, it's pretty unlikely that migraine headaches are going to get better with Chiari surgery. Right? Those posterior tussive headaches almost always will. But this patient also happened to have a syrinx. Right? So, because of the syrinx, we went ahead and did the Chiari operation. And I got a little bit of one gory picture here for everybody. This is actually her brain. And she had a membrane blocking the spinal fluid pathway right at the base of the skull there, which we see in about 10% of kids with Chiari. After that, her headaches, she's had 2 migraines per month after surgery. So she still has them, but it's a pretty dramatic improvement, right? So what does that mean? I don't know what that means. That's one patient, and I don't know what to make of that. This is a patient, almost 2 years old, little boy, problems with swallowing, sleep apnea, not really. This AHI is the number we use to measure sleep apnea. Anything under 5 in a kid is pretty normal. He's having some coordination problems. He walks into walls, but hey, he's 2. Like 2-year-olds walk into walls sometimes. And behavioral challenges. We saw this patient and we said, this is very unlikely to be Chiari related. He actually went to another hospital, another center, and was offered Chiari surgery. And I actually don't know what happened. I'm not sure he's ever had the surgery. But I bring this up just to point out that there's differences of opinion at different centers about what is likely to respond to Chiari surgery and what isn't. And one last patient, this is an 8-year-old girl. You can see the Chiari here, right? So there's the front of the foramen magnum, there's the back. You draw that line, the Chiari's down there. Got a little bit of fluid in the spinal cord, right? So that's going to meet most people's criteria. But also, we noticed that she's got another condition. She's got excess fluid in the upper part of the brain called hydrocephalus. And we treated her hydrocephalus, and the Chiari got better. And so now you can see the cerebellum's come up a little ways, the fluid in the spinal cord's gone. And so I bring these up to say this is difficult, it's complicated. Like sometimes it's really easy. You say, okay, you got these symptoms, you got this syrinx, I know what to do. I'm going to take you to surgery. If you don't want to have surgery, I'm going to work hard to convince you, particularly if there's Syringomyelia, right? I'm going to try to convince you that you need an operation because we think that's the best thing. Other times, I'm pretty uncertain if what you've got is going to be helpful or not, or is going to be helped by surgery or not. This is a word cloud of what you find on the internet if you search for Chiari. Notice that Syringomyelia is in there somewhere, but I can't find it.
It's in the middle.
Okay, great. There's lots of stuff on here. Fibromyalgia is a chronic pain syndrome. Headaches, of course, dizziness, anxiety. There's lots of symptoms that I didn't describe as classic Chiari symptoms here. All right, so if we're going to try to figure this out, we want to look into the medical literature. And if you just do a search in the PubMed, that's the database of medical literature, for Chiari plus fibromyalgia, you get a bunch of papers. Chiari and autism, you get a bunch of papers. Is Chiari related to autism? I don't know. I don't think so, but I can't say for sure. Ehlers-Danlos is a connective tissue condition with hypermobility. Lots of interest in that over the last couple of years. But I don't know if Chiari surgery is helpful for a lot of those conditions. And this is the biggest question that in our field, in my opinion. Are we missing patients that we could help? Am I specifically missing patients that we could help? Because my approach to this condition, as we've discussed, is very, I'll call it conservative, right? You got these three things, a specific type of headaches, syrinx, sleep apnea. I'm going to offer you surgery. Otherwise, we're going to have a long conversation about how likely Chiari surgery is going to be to help you. And we may or may not eventually agree to do surgery, but it's going to be a long talk. So how would we figure out an answer to this question? And the answer to that is we need a lot of collaborative research. We need a big group of centers that are studying this question. This we've started to do with the help of the Bobby Jones Chiari Syringomyelia Foundation. We've assembled, I think, what are we up to now? 13, 15, 19 centers?
22.
22 centers, right, that are contributing patients who have had Chiari surgery. They're asking them questions about their symptoms before surgery. They're capturing details of what their MRI looks like, what their surgery entails, and what they're like afterwards. And the goal is to figure out who's going to benefit from Chiari surgery. But this isn't enough, because the big problem with this study as we're doing it right now, one, we don't have any money, so we have to just figure out who's going to actually do the work of coming in and collecting this data. Thank you, Claudia. Right, we need volunteers right now, like students who want to get involved just because they want to get involved to help us with this. But we only are collecting patients who had surgery. You can see the problem here, right? If I see you and I say you don't need surgery, and you're not in the study, right? That's an issue. So in order to answer this question, really what we need is a big study, lots of centers, where we recruit all the patients, right? So if you get referred to a center for Chiari, regardless of whether someone decides you need surgery or not, you need to be enrolled in the study. And then we need to have, as Dorothy mentioned, and some of you were here, independent follow-up, right? So whether or not you have surgery, you get a call from a third party to say, how are you doing? How are those symptoms? What's happened to you since that initial visit? Now, the way this will work, if it ever works, it would have to be a very, very large study, because we have to count on the fact that different centers approach Chiari different ways. So if you see me, and you're like, I don't like that guy, I'm going to go see somebody else up in New England, and they say, you need surgery, right? You're still in the study, and now we know what you were like when you came to my clinic, what you were like when you went to that clinic. Then you have surgery there, and you get better, and I learn, I didn't have the right idea about Chiari. Of course, the other thing could happen where you have surgery there and you don't get any better, and I like, yeah, it was right after all. And I'm sorry you had that extra surgery. But this is crucial, right? This is what we need in order to understand this condition. And we are working towards this. We got a long ways to go, but the centers are coming on board slowly. And the key thing that we're going to need to do is have research participation. So I really appreciate all of you guys who have come to our clinic and agreed to participate in research. I know that everybody's agreed to participate because we haven't had anybody say no in the last 3 years. That's thanks to Caroline and the team. But yeah, that's what I have prepared. So we have a huge team. This is an old slide, so it doesn't have all the students' names on it. This is my family. With plenty of time for you to take me back to things I didn't cover enough and ask questions and talk more.
You said that about the Dura patch?
Yes.
Is that like a synthetic? You take it from somewhere else in the body and use animal?
So let's talk more about that. Great. There are two very widely accepted ways to do Chiari surgery. There's with a patch and without a patch. Okay? I'm going to put the one intraoperative photo back up. So if we do what's called a bone-only Chiari decompression, right? We move the muscle and skin out of the way, we take off the window of bone, we're looking at the dura looks good, we close everything back up. That's a bone-only surgery, right? That's one way to do the operation. Another way to do the operation is with a duraplasty. So we do the bone, and we open the dura, and we sew in a patch to make the space larger. There was a very large study comparing those two operations, led by a guy named Dave Limbrick out of WashU. Now, the one caveat to this is that every patient in that study had Syringomyelia, right? Somebody calling us? It's actually somebody's calling us. Okay. And the reason for that is it's easy to say, did you get better or not? It's a picture, right? Did the syrinx get better or not? And the answer was both surgeries were essentially equally effective. Now, what I learned from Dr. Oakes is that 8% of patients are going to have this membrane blocking the outlet of the fourth ventricle. So that's a space that spinal fluid needs to be able to move through. If you do a bone-only operation, you're not going to check for this. So you're going to miss it in 8% of patients that have Syringomyelia. So we always do a duraplasty. Now, the question is, right, a bone-only operation is a little bit simpler, so it has a slightly lower risk of complications, of bad things happening. So should you do the duraplasty depends on what's your surgeon's personal rate of complications. If it's too high, then bone-only is the right operation. If it's low, then the duraplasty is probably the right operation. Right? I haven't even come close to answering your question yet.
No, it's been good.
What do you use for a duraplasty? There's all kinds of options. So my personal opinion, the best option we want to use is called autologous tissue. So that's tissue from your own body. So we take a piece of the lining of the skull. Right? So every bone has a membrane along it called periosteum, includes your skull. So we make a little incision, scrape off a little piece of that lining of the skull and sew that in to use as a patch. Works great. It's your tissue, so you don't reject it. There are synthetic options. People have put in things like Gore-Tex. There's actually the lining of a cow heart, bovine pericardium is a very common one that's used. There's all kinds of options. They all work, and they all have different pluses and minuses. I like the periosteum personally.
Cool.
Thank you. Take the gory picture off now, sorry.
I got a question. When we learned about Chiari, I figured out that the only thing I can understand about it, I'm not a doctor, of course, but I can understand there was the MRI and the symptoms. On the other hand, it seems that the problem is some kind of compression and pressure adapted to that point. So I was always wondering why nobody checks the pressure.
Yeah. So the short answer is we have some. There have been some studies on this, and this question of can we find an easy way to determine who's going to benefit from Chiari surgery? We've tried all of the easy methods. So we actually did a study looking at, I think it was like 25 different specific measurements that you can make on an MRI scan. None of them predicted whether you would have symptoms or not. There are studies, there's MRI techniques that you can use to measure how the spinal fluid moves through that space. They're not that useful either, right? They're kind of like a coin toss. People have put, right, to measure the pressure in that space, we actually would have to open it and put a probe in there. So you can put a very tiny pressure monitoring wire through the bone into that tissue, and you'll find that's called the intracranial pressure. It's pretty much normal in everybody. So that study was done on by a surgeon who was going to be doing a Chiari surgery anyway. So had the patient ready for the surgery, and before opening the bone, made a small hole, put the pressure monitor in, and checked to see are these pressures normal, and they were. So all the easy answers we've tried to find and haven't found them. Does that answer your question? As best I understand this condition, the symptoms are caused by, right, too much tissue in the opening that's messing with the way the spinal fluid wants to move with every heartbeat. Right? And so what we do, we make more space, we make more room for that spinal fluid, and symptoms go away. It's the basic principle. You're allowed to be skeptical. I'm skeptical too.
I don't know.
Yeah. I'm giving you my best explanation. That's what we know. Go ahead.
So we actually work with 40 biofluid engineers from around the country. We host a hydrodynamic symposium, which is a global event every 2 years. We're going to have one this year in Germany. But they're actually working on software that looks at the compliance of the brain with the
Yes,
pressure.
that's right.
And,
That's right.
there are one's going on at Northeastern, and we're working with John Oshinsky at Emory on the new software, which is actually kind of what you're talking about, like looking at how.
Yeah, there's some promising ideas there. Yeah, I'll mention three. Everything uses MRI because MRI is like a magical technology. It's really quite remarkable what we can learn. So there's MRI flow studies where we can watch how the fluid moves through that space. We already know those aren't that useful. There's MRI displacement studies where you can actually watch with each heartbeat how does the brain tissue move, because the brain moves when your heart beats. There's a little pulsation of the brain. So we think maybe if the brain's moving too much, that might be a sign that there's more likely to be symptoms. And then there's a third technique where we can actually measure the stiffness of the brain. Right? The brain is kind of like firm jello. If you touch it, your finger's not going to sink into it, but if you push too hard, it will. Right? So that's what brain is actually like. So, and it can change in its stiffness based on a whole bunch of different things. So one theory is that there's a brain tissue stiffness problem that's part of the issue. We're actually working on getting that technology here. It's used to measure the stiffness of livers already. Like that technology exists for measuring cirrhosis and things like that, liver disease. It's actually pretty cool. What it involves is vibrating the patient really quickly and then measuring how the tissue moves. So we have to do this in the brain, we have to put your head on a pillow, and then we hook it up to like a subwoofer, like a deep bass speaker, and you just, right, and your head vibrates a tiny little bit, and we watch how your brain reacts. So that's hopefully coming here within the year. But I don't know what we're going to learn from it. We're going to learn something.
Is Chiari typically genetics?
Yeah. That's a great question. Great question. So it does sometimes run in families. There are definitely people that have multiple family members with Chiari. We had some here, right?
Mom and
Yeah,
daughter.
yeah. Most Chiari's does not have an affected family member. But as you saw, right, like 3% of the population, 1 to 3%, that's a lot. So maybe it's coincidence. I don't think it's likely to be coincidence. There's probably a genetic component to it. So the way to do that study would be to test, right? Test for genetic abnormalities. There's been lots of those studies. There are some genes that have been identified. It's not like, Down syndrome or some clear genetic disease where we can say, okay, if you have this gene, you're going to have Chiari. It's much more complicated than that. There's probably a genetic component. Chiari, as best we know it, it's something you're born with, right? The cerebellum doesn't go down there; it starts down there from as soon as the brain is developed. So, if it's happening as you're developing, there's probably some genetic component to it, although we haven't figured out exactly what it is. It's a long answer to a simple question if I don't know.
We don't know anybody in the family that has this,
Mm-hmm.
so I was just,
Most people do not have an affected family member. That's the norm, right? You're just lucky.
are pediatricians being updated on this? Because, I mean, I'll be honest, I had a lot of anger towards
Yeah,
that pediatrician. And when I was at work, her pediatric office, she moved, and I actually ended up seeing her on one of my work days.
Mm-hmm.
And she was like, oh, how's your daughter doing? I was like, oh, she's scheduled for neurosurgery. All those headaches she kept saying for 4 years ended up being Chiari's.
Yeah.
She was just blown out of the water. She was just shocked. I was like, yeah, you might want to start paying attention to people when they keep saying they have headaches back in the back.
Yeah, that's a good point. So we certainly do some education with pediatricians. All of my referrals come from pediatricians, so we give follow-up to people that refer us patients. The best avenue for that would be the American Academy of Pediatrics. I'm going to work on that because, as it turns out, I'm on the board, the board of the section on neurological surgery at the American Academy of Pediatrics, and we in the neurosurgery group, our main job is to educate the pediatricians in the broader membership. So. We certainly do, and pediatricians, the problem is that primary care docs have to know everything. I have to know a lot about a very tiny number of conditions, right? They got to have a broad knowledge of the entire body, so there's only so much you can think about. Yeah.
But it was like
But you're right.
years of straight
Yeah.
complaints of the same thing. You would
Yep.
think that, oh, well, maybe I need to think outside the box.
Yeah.
That's just, and then we got a new pediatrician, and she immediately said, you're going to a neurologist.
Yeah. It's a lot of it's based on your experience, right? As soon as you've had one kid who has Chiari, you're going to remember that. Right? So I don't know.
I'd like to piggyback off that.
Oh, sorry, I'm asking
Because-
headaches, but you go ahead.
Yeah, I was gonna piggyback because our pediatrician, she got the MRI and got diagnosed, and she just kind of left it into my hands.
Okay.
Like, do you
Huh.
want to be referred to a neurosurgery? And because I have it and I've had
Yeah,
decompression, I said absolutely.
Yeah.
On a baseline, so I kind of agree.
Yeah. I think that, I don't, I'm not a pediatrician. I don't know. What I'm going with that is that I'm not exactly sure how they think about these referrals.
Yeah.
Everybody who gets to me
And I know you don't
has been referred, right?
refer everybody.
Because you can't get into me without a referral. Nobody can just call and get an appointment. You've probably noticed that. Yep.
I just was gonna ask about the headaches.
Mm-hmm.
So we are seeing a migraine specialist next week, actually. But all of our headaches are right here. Migraines, if that's what they are, they're always back there.
Yep.
And we do have the sharp coughing, like we do have those. But sometimes it's not just a short.
Yeah, yeah,
And so,
yeah.
like, I guess that's what is a little frustrating, because we do have the dizziness and we
Mm-hmm.
have the uncoordinated, like sometimes we get, I love you, but you run into things. And like we just.
And you're not too.
And she has a larger one, like hers is 20 millimeters, like it is a large, or what they've told me is larger. But I guess like we all were talking about, is that what y'all are gonna do in that big study, is look at more of some of the other?
Well, yes. So my approach to this would be, like, if you have sleep apnea, if you have Syringomyelia, I'm going to recommend surgery because those things I'm confident the surgery can help and they're going to make you healthier. Right? Headaches are a different ball game because the question is, do you want to go through this kind of
But
big
what if
surgery?
What if it got rid of them?
Well, yeah, right. That's exactly where I'm going. It's kind of a big surgery for your headache relief. Now, I get headaches sometimes, but they're not that bad, and I wouldn't have the surgery, even if I knew they were from Chiari. But that's because my headaches aren't that bad, right? That's a question that you have to think about. And if you say, look, these headaches are awful, they're happening all the time, they're totally running my life, right? I personally would be willing to say, okay, let's give it a shot, recognizing that I'm confident that the sharp cough-associated headaches are going to go away. I'm less confident that other headaches are going to go
The
away.
dizziness and all that may or may not. That's one
It
of
may or
those
may
things.
not. It's what I would tell you is it's probably 50-50. Now, the more Chiari-like symptoms you have, the more confident I am that more of them are going to get better with surgery, because that, they would all hang together pretty nicely there.
Some of the research, if I read it correctly,
Mhm.
which, I've tried to go to like Cincinnati and the
Yep.
places like that. But it seems like a lot of people that have it when they're younger and they have larger ones are more likely to have surgery as adults.
Yeah, that's an interesting question. I don't know that we know that, because there's not been really good quality, very
It doesn't mean
long-term
it's
studies,
not
right?
great.
Those studies don't exist.
But the ones with larger Chiaris
Yeah.
tended, there's like a percentage, I don't remember what I read.
Yeah. I don't know. I will tell you that my personal approach to this is if headaches are the main reason we're going to do surgery.
It's not worth it.
Well, no, that's not what I'm going to say.
Okay.
It very much is. It very much is in some circumstances. But what I will do is make you come back and see me in 6 months. And 6 months may seem like a long time, but if I'm not sure that Chiari is your problem, I want to sit on it. I want to think about it. I want you to be thinking. I want to give you all the information and have you think about it. And you come back, and I've had plenty of parents who come back and say, yep, we know it may not work, but this is awful. We got to give it a try. And, we've had good success with that. So that's sometimes the reason for a delay, is that I'm just not confident that it's going to get better. And I want to collect more
When
information.
you have weird symptoms, like not being
Yeah.
able to walk,
Yeah.
and like we have numbness and tingling, and the dizziness, like when you stand up, like just the different things that
Mhm.
affect daily life.
Yeah.
Even though, like, I don't mean this mean to physicians, I'm a nurse, I totally
Yeah.
respect physicians, but it might not be big when we walk in. Does that make sense to you?
Yeah.
Because what y'all are seeing compared to us might not be as big of a,
Yeah. What we're trying to do is make this a partnership, right? It's going to be a decision. That surgery, when it's not something obvious, right? Searing sleep apnea, right? When it's not something obvious, we got to come to a decision together about what the right thing to do is. And I have a hard time doing that personally on the first visit. If you just walked into my office, we've just met, I'm giving you this whole spiel about Chiari, and then I say, you want to have surgery? And that's a hard question, right?
yeah.
So I think stretching it out, and 6 months does kind of seem like a long time. In our hospital, it takes 3 months to get a sleep study, so that eats up some of that time. You have a question?
Yeah, so what is big? Because when we went to
What is big?
yeah, so
Yeah.
it's like you say Bob's cut off.
It's a great
When
question.
we were in the emergency room, they're like, "Oh, this is no big deal. It's barely a Chiari."
That was with the
But
CAT scan.
but then we found out it was like 15. I'm like, "Oh, that's a big number." Then you say 20. I'm like, "Well, that's even a bigger
Well, that
number."
was
It's
too-
like- and look, I'm not good with millimeters, but like
This
once you get
one-
to 20, I'm like, it's halfway down your spine or
We
something.
got good. I got good data on this, and I can confidently tell you that the distance that your cerebellum is outside of the foramen magnum does not
Doesn't matter.
make a difference. Right? It does not predict whether you're going to have symptoms or not, whether you're going to respond to surgery or not. That study was done over and over and over again because it seems obvious, right? The lower those tonsils are, the
gotta
more
be.
likely that's the problem. Right? Turns out that's not the case. We have kids who have their tonsils 1 millimeter outside the foramen magnum, but things are just tight, and they have a huge syrinx. It's a really big deal, and we know we have to do surgery, and they get better. And we have kids that have 25 millimeters of tonsil, descent, and they're totally asymptomatic. We're like, what are you talking about? I'm fine. Right? And we follow those kids because, of course, we know that the tonsil position doesn't matter, but it still scares us.
Yeah.
So we keep doing the MRI scans, and they're fine. Right? So that one, that's the reason why that measurement is not. We don't put a lot of weight on
It's a
it.
scary number though.
Yeah, but that one we know you don't have to worry about.
That's why I was asking about the others.
Yep.
Yeah.
Yep.
Because hers is larger,
Significant.
but it's, we don't have the syrinx, and we aren't having, like we're not having the big ones, the big three.
Yep. Yep.
And so we do have other symptoms, you know what I mean? Like,
Oh, yeah.
Anyways,
My follow-up to that, so my story about my aunt, she was the odd one where they said 50-50, you can have it or not, and then 40 years later, here she is with a lot of symptoms. Hers was really small,
so it doesn't matter. Hers, that's why they told her it probably won't help you if you have it. It was very, very small. I can't remember the exact number. But I think, I don't know, this is my kind of question for you that I don't really know. We're both smaller people. Me and my aunt, she's about my size. Like, just generally smaller people. Does that have something more to do with it? Who knows?
You got me there. I don't actually know if we've studied the size of the person. Like height? Yeah, I don't have the answer to that one.
It's just like, so like my kind of comparison is that like I had a kidney stone this past summer. So like on me, it was too big to pass, but it wasn't big enough. Like the first round, they were like, just go home, you'll pass it.
Yeah, they're used to 60-year-old men, right?
I'm like, I'm 100 pounds soaking wet. Like, I'm a little bit different than your typical patient. And so I ended up having the surgery. And that's where it kind of spiraled that whole thought for me. Is like, okay, my aunts, we're very similar. Like everyone thinks that I'm her daughter. Like we look exactly like. And that's kind of what spiraled that thought for me is, okay, she's a smaller person. She has a smaller school. I mean, that's just how it works. Does that have anything to do with it? Who knows? I don't know. But in her case, maybe it did because she does have symptoms now.
I've honestly had that same thought too, just because she's petite, she's
Yeah.
4'11", and she had two, like her mouth was crowded, so she had to have multiple teeth pulled. Did anybody, did y'all have that? Because there's tooth crowding.
I have 3 categories of answers I can give you. One is stuff that I'm very confident about because we've studied it and we know. I have one category that's just, this is my opinion, I'm going to tell you it. And then there's things I believe but I can't prove. I think that the problem with Chiari is too much tissue in the space messing with the way spinal fluid moves. Could I see that the size of the person might affect that? Right? If you have a small spinal canal and a small, or even a normal size spinal cord in a small spinal canal, might you be more likely to have symptoms? I could see how that might work, but I don't have a medical study answer to that question.
Could you educate this group a little bit about the evidence in papers? Like there are different.
Oh, that's a great question. Thank you. Yes.
Meeting, and I think it would be very helpful.
Let's see. I think I might have.
You don't go to mommyblogger.com?
Well, even in journals, like people, you see a study published by X doctor with a number of patients. How much should you trust that study? Or
Okay.
yeah.
This graph is not as helpful as I thought it was going to be.
It looks great.
There's no number on the y-axis. It's like this represents 6,000 papers in the medical literature on Chiari. 6,000 papers. And so we grade medical literature on how much we should trust it. Right? The best study is called a randomized controlled trial. I got a bunch of patients. They all have the same condition. They all have exactly the same condition. And we assign them randomly, coin toss, however you like, into 2 groups, 2 different treatments, and we see what happens. And then we know if one of those treatments is better than the other. So randomized controlled trial, best type of study, impossible to do, especially with surgery. The one study I mentioned earlier about comparing bone only versus duroplasty, it was that kind of study. I think that's the only one that we've ever done in Chiari, a randomized controlled trial. Below that, you have what's called a cohort study. Right? We're going to grab a whole bunch of patients, as many as we possibly can, and we're going to follow them and see what happens to them over time. A prospective cohort study. You get enrolled at the beginning, and we see what happens to you. Thousands of patients. That's what we're trying to do. That's what I described to you earlier. There's very few of those in Chiari. Don't know. Okay, maybe 1 or 2. You can do the retrospective cohort study, where you take a whole bunch of patients that you found and then you try to look back in their records and see what they were like before. That's not as good. There's more of those. And then you have useless studies, almost useless. There are case studies or case reports where, as much as I love Dr. Oakes, right, that 500 Chiari's paper is his case series. This is just him saying, I've done 500 operations now. Here's what they looked like. And in 2011, that was a study that could get published. Things have changed, and you can't get that kind of study published very easily anymore because it's not very high quality. I don't learn as much from a study like that. The vast majority of these 6,000 papers are reports of what happens to 1 or 2 or a dozen people, and it's really hard to make heads or tail of that. A lot of what you see on the internet is based on those very small studies or small numbers of patients, and I don't know what to do with that. That's why I recommend you go to CSF website for internet information. That was an interesting question, thank you.
Yeah, no, it is, and I'm gonna go one more for you, so.
Oh, there's a follow-up, good.
So we did the common data elements, which is, so we could compare apples to apples, which is important step. But then we also worked on the clinical guidelines for Chiari. And
Oh, yeah.
I
yeah,
think
yeah.
that was very eye-opening as a parent of a child.
Yeah. Have you guys heard of guidelines? Is that what your question would be about guidelines?
And the
You're familiar with the idea of guidelines, right? So in medicine, we try to practice what's called evidence-based medicine, where instead of me just saying, this is what I think we should do, I'm trying to base my decisions on what we know based on those high-quality randomized trials. So medical organizations will put together guidelines for the care of X, right? So if you have a heart problem, the American Cardiology, what is it, the American Heart Association, they have done hundreds of studies with thousands of patients each, and they say, okay, in this situation, when you have this condition, the best practice is to do this. Those are guidelines, they're assembled based on the synthesis of all of the evidence. We did that in Chiari 2 or 3 years ago, and we found that we couldn't make any guidelines. We couldn't say anything definitively because we don't have good enough quality evidence. Right? There's rules about what you're allowed to say in guidelines based on how good the evidence is. And we kind of had to say, we don't know. Except, we know that the syrinx get smaller if you do Chiari surgery. And we're pretty sure those headaches get better. That's about it.
So the point is you have to do more research, and I know it's like this awful process because it takes forever. Everybody wants an answer tomorrow, right? We all want it tomorrow. But it's something that Dr. Rocque and everybody's really leading the charge on. And, you know, in 5-10 years, we will have all those answers. And I think that's the point. That's why it's important now to get these going. So.
I have a question I don't even know how to really ask, but is there any kind of data or study on pain tolerance?
Oh, yeah. That.
I mean, because I did not know how bad I hurt my whole entire life until I woke up from surgery.
I don't know the answer to that. So
Okay.
I don't know how to study that. I think I'd have to.
I don't even know if it's possible.
I don't know if it's possible either, right? How do you perceive pain?
Right.
Right, how does somebody else-
My husband,
Yeah.
I'm married to my husband, he's never had a
Yeah.
migraine.
Yeah.
And it's like I woke up and I was giddy, like, wow, my head hurt
Yeah.
that bad
Yeah.
all the time. But it's just kind of, I'm like, are we just a tougher breed?
So, I think people-
right?
People tend to make judgments about pain tolerance based on how did one person react to the same injury or same thing as another person, right? And that there might be some validity to that, but at the same time, like, we don't know. Like, childbirth is always given as an example of like a really painful thing, but some people experience it different than others. Right? Not everybody is the same. It's like a benchmark, right? You know, does a woman who makes through natural childbirth have a much higher pain tolerance? I don't know. I don't know the answer to that. It's a really hard thing to study.
So how can we help?
How can you help? That's a lovely question. Thank you.
Not me, I mean, in this case, that's gonna be her. But, I mean, that's, it looks like that you have a data problem, right?
We do. So I have two answers to that. Number one, most important, is participate in studies. If you have the opportunity to be a participant in a research study, please take it. We make sure that if you are in a study, you receive the best possible care, the care you would have gotten outside of the study. It does not mean that you're not getting a treatment, right? You're not a guinea pig. We're not doing experiments on you. We are collecting information about you, about your condition. So participate in research in any opportunity you can. And then I'll make a shameless plug. We always need funding for research. So if you have the means, Children's of Alabama, CSF, you know, we would happily take donations. Those are the only answers I can come up with.
So they're diagnosed as a pediatric patient. As they phase out into adulthood, do y'all still follow them?
Yeah. So transition to adult care happens to be another area that I work a lot in. It's a hot topic in pediatrics in general and pediatric neurosurgery specifically over the last, I'd say, 2 or 3 years. What happens when you turn 18, 19, 21, whatever it is, the age that your hospital no longer sees you? Here at our center, we have a very robust transition program. We do a transition education program starting usually around 14, 15, 16, if you need it, right? How is it going to be different for you in the adult care environment? At age 21, we actually make the move over to the adult world. It doesn't apply most of the time to Chiari, but if you have complex medical needs with lots of different physicians, we have a specialized clinic that is there to coordinate moving all of your care from one hospital to the other. And then we'll get you plugged in with an adult neurosurgeon to take care of Chiari issues for you in the future if you need it. Like that's what we do here. Every hospital does transition a little bit differently. And it's a tough time. Things get lost. We're doing everything we can to minimize that, to make it smooth, make sure information doesn't get lost. But it's a risky period. You were chuckling over there. How are we doing? You have feedback?
Well, you were like, you get kicked out at 21, and I turned 20 in like 2 months, and I was like, oh no, my time's running out.
Here's what I'll say. There's a caveat to that. Children's of Alabama would rather not take care of people who are over the age of 21, but they're very accommodating. So if we have a patient who's like, hey, this patient needs surgery, they're about to turn 22, can I do it here? They're going to say, no problem. Right? We're not going to make you go get a new doctor at age 22. But if you're 21 and like, you might need surgery in 3 years, we're going to get you transitioned to the adult world. People that have lots of difficult pediatric conditions that mostly pediatric doctors take care of, Children's is really good about letting us keep them here, for longer. Although eventually you start getting adult medical problems, and like the anesthesia team doesn't like that, the pediatricians don't like that, they don't know what to do with it, and you get better care then at the adult facility. So those are things we have to consider too.
Cardiology does a good job with children's moving much older. So.
Yeah, the cardiologists they've really got it dialed in.
So what studies should she be involved in? Yeah, start asking me questions, I'll answer. I just don't know.
It's like 75
When did you have your surgery?
Here?
When?
4 years.
Almost 4 years ago.
I don't know. Yeah, that might have been right before we started. I don't know. We'll get you. Hopefully you don't have to have another surgery.
I don't think so.
I will say too, I know at least for our surgical success study, we do a really good job too, making it very limited for what y'all have to do outside of clinic and everything. So I think sometimes when you get, as a patient approach research, you think it's going to be hours on end and phone calls after and us bugging you, to fill out the surveys and everything, or kind of things you have to come in and go outside of clinic to see us. But they do an amazing job of that. It's mostly the surgeon doing a lot of the clinical data entry and the imaging and everything. And then we just ask you 5-minute less surveys. Try to help out with that.
Are there specific post-op research?
We do 2 to 5 months after the same surveys, and then we do 10 to 18 months.
Well, what if we're 15 years post-op?
Yeah, answer that more about.
I'm like, can I contribute
ongoing.
anything in my old age? No. Not right. We're not.
Not right now.
Not right now,
now.
But we're getting there. I think that was the whole point. We realized in the foundation that there were people who would go to a surgeon, maybe not get surgery, and they were good. They were written off as everything's great, and then we find out they're down the road with somebody else getting a surgery, and nobody's following all of that. And it's so important to know what really happens to everybody.
Yeah, I had a checkup and that was it.
Yeah, so, but we're, just give us 6 months. We're working on, and I have a thing for you to participate in. Okay, great.
All right, there you go.
Yeah, we're getting a new app. So
Just
we'll
what I
get you
need.
to try that.
I have a question. Our daughter is having symptoms. She has hypermobility, and I'm wondering about her having ED. And how will that affect, and how can we distinguich between this is Chiari and this is that?
Yep.
we have a referral to a geneticist, but that's gonna take forever.
It's gonna take a while, so.
And how do you handle those patients as far as surgery?
I don't have confidence that I know how well Chiari and Ehlers-Danlos are linked. I have a lot of colleagues who are like, these go together. You do Chiari surgery and it helps with some of these symptoms. And I'm frankly just not convinced. Like I reviewed their studies and I'm like, I'm not sure that's real, what you're seeing there. So I'm pretty careful about that. Genetics is important, right? But there are forms of hypermobility that don't have a specific genetic marker. So genetics may be normal. If the genetics tests are positive and you have a confirmed diagnosis, well then we actually have to also be a little bit careful because the surgery may actually carry a little bit higher risks. Right? So there's a lot that goes into that. And all the same things.
Do you want to wait on all that, before you would proceed to?
If you have sleep apnea, Syringomyelia, right? Posterior chest headaches, but in all seriousness, then I'm not going to wait because these things are dangerous, right? Sleep apnea, and we're going to say, okay, I know that you might have these other conditions, but I'm going to do this for this reason. But if we're in that gray zone and I'm not sure, then I think the right move is to let things play out for a while.
And do you need a MRI, a brain MRI to know if you have hydrocephalus, or is that something you would know from the spinal stuff?
It depends on what was on the spinal MRI, because the spine MRI includes the bottom part of the brain, and a lot of times we get enough. Yeah. Well, I am not talking about your specific case. I am talking in general.
Right.
We have. I am not giving medical advice here. This is a general principles talk. Usually we can tell. Are you the youngest audience member? Probably. You're sticking it out pretty well. This is a long talk. Cool. No. Can we go? Yeah. And then I praise you for being such a good audience member. Yeah. I think that's an excellent note to end on. Thanks everybody for coming. This is a lot of fun. I hope it was helpful for you guys.
Thank you.